right, well, welcome everybody. My name's Holly Wittenberg, and I'm with Diversity Works. Joined here by my two business partners, Elizabeth and Denise. Stick around for Denise's panel later today. What we hope to do today is introduce the panel, let them introduce themselves. Then we're going to let them share their stories, and some of these stories are lived experience, others are commercial, more business-related experiences, all of which fall under the umbrella of healthcare, structural inequities, and racism. And then the third part is we'll talk about what we can do about it, or what is the policy ask that we seek to accomplish. So with that, I just want to share with you a couple slides that we'll make available after this presentation. So Brady, if you wouldn't mind going to the first slide. Just a reminder that this was a priority of Biden that requires agencies to create DEI committees and to do things to reduce racial disparity. So healthcare is funded in large part by government money and government programs through Medicare, Medicaid. And so if we're not seeing the progress that we need to remind HHS that this is one of their priorities and we need to see progress further down. Next slide, please. Very quickly, there's no way to encompass all of healthcare inequity on a single slide, but Denise and I worked on this slide, and we wanted to talk about really 4 different areas. One is the historical trust issues, and we're lucky here to have someone expert on the Tuskegee Airmen experiments. We'll talk a little bit about that. Access to new drugs and technologies, and we're going to show you some data on clinical trial access. The horrible, poor differences in outcomes, and then last but not least, representation. In other words, do we see Black providers or minority providers being able to serve their communities? So next slide, and again, I'm not going to spend a lot of time here, I just want to walk you through them. So as we said, there's historical mistrust, and here are 3 examples. It's the Tuskegee Airmen study, which infected Black airmen with a live virus and didn't treat them for it to study the impact, which is so horrifying, it's hard to even believe. Henrietta Lacks, whose cells have been used to the benefit of many pharmaceutical companies and research groups without compensation to her family, although I think they did change that. And third, underfunding of diseases that are predominantly in the Black community, like sickle cell disease, when similar diseases with the same prevalence and incidence actually are funded at a much higher rate. Next slide, please. And this is just more data to show that the life expectancy, those outcomes, so you can look at a variety of different health outcomes, but you know, mortality is the end of the day what it's all about, right? And this is a sad state of affairs, but as you can see, Black mortality is the only group worse are American Indian and the Pacific Native groups. So the other thing to note about the life expectancy is the Hispanic and Asians are actually exceeding the average, which is some positive news in the scope of minority health outcomes. Next slide, please. If you look at this chart, this is about clinical trial participation. I recently learned that clinical trials just started capturing demographic data. So this is also a new data set that in the last couple years. But what you can see is that although Blacks are 13% of the population, they're only 10% of clinical trial participants. And that is actually also related to historic mistrust. So we've got to work on these issues in tandem. Next slide, please, and then we'll move into introductions. And this is the breakdown of providers, of primary care physicians by race. And again, you can see that there are only 5% African-American providers for a population that's 13% Black. So a lot of work to do. Just wanted to share this data quickly. Happy to share it with anybody that's interested in. Brady has a copy. He's showing it to you right now. All right, with that, I want to thank the panel for taking time. And why don't we start on the end and have everybody introduce themselves, and then we'll move into everybody sharing their stories.
Good afternoon. I'm Wesley Hodges of the Hodges Foundation, Rural and Economic Development Foundation in Alabama. That's where it's based. We service about 18 counties in Alabama, but we also seek to serve in the end game pretty much all the way up about 13 to 15 states. And this is for rural and economic development across the board. So that entails quite a bit of things, and for the sake of this particular panel, healthcare is one of those. In our Health and Human Resources Department, where we have taken a lot of man hours developing capacity, personnel, and also plans to be proposed for rural health initiatives. And we think we've come up with a model that is conducive to moving through several areas in the Black Belt you don't have to have, I guess, a dense population in order to move these programs across the board. So I look forward to hearing the opportunities and the programs that each of these panel members have to present. And if you have any questions for me later on, that's fine. Regarding the foundation and the Health and Human Services Department, fine. Any other department you can ask about as well. But that's my spiel. Stillman College, University of Alabama, education. I'm just here to work. Thanks.
Thank you, Wesley.
Awesome. I'm Tamiko Stanley. I'm the Chief Diversity, Equity, and Inclusion Officer for Elite Executive Strategies. I've been a Chief Diversity, Equity, and Inclusion Officer, I'll just say, for 30 plus years, working in industries that include sports, but specifically healthcare. I've spent 8.5 years at Luminous Health here in the DMV, and my background is also working with FedEx in sports and entertainment with the Pittsburgh Pirates, and in health policy, serving the city of Pittsburgh through 4 mayors as the Chief Diversity, Equity, and Inclusion Officer across the city. And so I am very happy to be here. I want to say a huge thank you to Kevin, Brady, Kia, and the team for continuing to put on the summit. We have to have these conversations. I know sometimes talking feels like it's frustrating because we want to do action, but this dialogue is important, and I'm very pleased to be here and looking forward to the conversation today.
Thank you. Thomas Johnson, I'm the Executive Director of ASAP 340B. We're a coalition of about 18 organizations that are looking to seek reforms in the 340B drug discount program. I also currently serve as chair of the board of the Sickle Cell Disease Association of America. I'm in my 3rd year in that capacity. I have also served as president and CEO of the DC Hospital Association. I've served as vice president of a former Medicaid managed care plan called Chartered Health Plan that was based in DC and was the first Medicaid HMO and first African American owned Medicaid HMO in this country. I also served for 9 years as president and CEO of the Medicaid Health Plans of America. They are an organization representing health insurance countries that have Medicaid lines of business, for-profit and nonprofit, around the country, and happy to be a part of this panel.
Good afternoon. My name is Sajda Wendy Muhammad. I'm a business and real estate developer and urban historic preservationist. I've spent a considerable amount of my career as a business developer in healthcare development, helping to develop micro hospitals, clinics, surgery centers. I currently work and have a practice where I'm helping individual providers to come out of the big box system and into their own practices. And one of my goals here here today is to advocate for independent, Black-owned and independent healthcare facilities that serve our underserved communities because of the amount of discrimination and hate and antitrust that we experience in trying to build and develop these centers, just simply trying to service our underserved community. So I'm looking forward to the conversation. I thank you all for the invitation, and thank you to Brady, Kia. Thank you all for inviting me.
Thank you, Dr. Mohammed.
Good afternoon. My name is Endora Govan. I'm the CEO of Color of Health, LLC. We provide at-home healthcare devices for those who have 3+ chronic illnesses. I also have a nonprofit, Color of Health Care. It provides consultancy to municipalities, to other nonprofits, and to community-based workers who work with people in underserved communities. So glad to be here.
Thank you. Good afternoon, everyone. I am Dr. Brenda Leith, and I'm the president and CEO of Leith & Associates. Leith & Associates is a health management consulting firm based here in the district. I am a native Washingtonian, and I am actually here representing the Tuskegee-Macon County Community Foundation. And the leader of that foundation is Dr. Lucinia Dunn, who was previously the mayor of Tuskegee and was deemed the first woman mayor of Tuskegee. So I am pleased not only to be representing her and the mission of TMCCF, which is what we call it, because its focus is on bridging the gaps and addressing disparities in the realms of economics and health. We believe that those two realms have to be addressed because they're codependent, and that is how one would be able to achieve good health and good, if they have a sound economic status. I also want to say thank you to inviting me to.
Okay. That's actually probably better than most of the audiences that I speak to that are not involved in the program. I'm going to talk to you about what this program is, why it's important to those who are underserved, what's been taking place, especially over the last 5 years, why we have come together as a coalition to try and seek reforms, and kind of what's at stake overall and where we think the program should go. So this program was created in 1992, and the statute says that this is a program that requires drug manufacturers to provide outpatient drugs to eligible health care organizations and covered entities at significantly reduced prices. The intent of the program is to allow covered entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. So that is the 340B program. Let me talk to you about some of the covered entities that are eligible to receive these discounts. They're broken out into 4 major categories. Number 1, federally qualified health centers, who have a great track record of serving the underserved.
Brady, can you move this slide forward, please?
Oh, I'm sorry.
That's okay.
Ryan White HIV/AIDS program grantees, hospitals, including disproportionate share hospitals and children's hospitals, and specialized clinics, including black lung clinics, STD clinics, and tuberculosis clinics. So I'm going to give you some numbers because I want you to understand the size and scope of this program. Number 1, this program now accounts for $54.6 billion in sales. which equates to $126.3 billion in gross sales. Why am I making a differentiation between the two? Because covered entities, on average, get their drugs at a 57% discount under this program. Okay? So that's why the numbers line up the way they are. The program has grown 169% over the last 5 years. Over the last 4 years, the program has grown by 22% annually. 1 in 4 brand drugs will be purchased at the 340B price level in 2025. By 2027, the average discount off-list price for drug purchases will go from 57% to 60%. And by 2028, there are estimates that this could be the largest federal drug program, exceeding the gross purchases throughout Medicare Part D, Part B, and Medicaid. So now you know that this program that you've never heard of is a very big program. So why have we come together as an alliance? We've come together as an alliance because the nature of this program, to make sure that those who are underserved receive a benefit from the discount that covered entities receive, that is not being applied consistently to the needs of the patients. And unfortunately, when you have a program that has very little oversight, you have 20 people in HRSA that are attempting to watch how $54 billion in money is spent that is not coming from federal funds. Okay, there are not enough people to audit to make sure that these covered entities are following the rules that they're supposed to follow. And there are not enough for them to see how this benefit, this drug discount, is getting to the patient. So we have a number of groups that have come together. The coalition's led by the community health centers, and they're led by pharma. And what the community health centers have told us, one of the concerns that they have is that by law, they are required to not resell the drugs that they purchase in this program by more than the federal poverty level, for people at the federal poverty level, at 200%. However, those same laws do not apply to hospitals. And we have seen hospitals mark up those same drugs that they've acquired at a discount of close to 60%. We've seen them resell those drugs at up to 500%. Okay? That means that if you are a payer in Medicaid, Medicare, commercial, that's the rate you're paying. You're not paying for the discount. Only the covered entity receives a discount. And there are some covered entities that are not marking up drug prices in this manner, and that's why they're part of our coalition. 87% of the dollars spent in this program go to hospitals. And unfortunately, what we've seen over the past couple of years, and they've been outlined in articles by the Wall Street Journal and New York Times, is that hospitals have now engaged in practices because they've read the law, they've read what's in the law, they've read what is not in the law. And they have engaged in practices that have helped their bottom line profitability. So I've told you about one with the drug markup. I'll tell you about another that is just as disturbing. Hospitals in those areas serving the underserved are starting to reduce the number of services at those sites. They are expanding their operations in more affluent counties and sites in smaller buildings. And then they are taking the same 340B discount and applying it to those sites. even though they're in an affluent area and not in an underserved area. That goes against the very nature of what the program is supposed to be about. But that's one of the reasons why, especially in the last 5 years, this program has grown as much as it's grown, and it's going to keep growing until Congress does something about it. So, I would like you all, I've got a whole lot of other things I could talk about with regards to this, but I want to leave you with some quotes and then leave you with some information as it relates to ASAP 340B.
And are you on slide 5 at this point? Which slide would you like them to?
This one's fine for now, yeah. So I want to leave you with some quotes, because, we're a coalition. We obviously have a certain feeling about things. The hospitals feel the program's fine. But I want to read some quotes to you. The first is from former U.S. Congressman Adolphus Towns from New York, who co-wrote an article with Reverend Ben Chavis, who used to run the NAACP. And the quote says, as we've seen recently in Richmond, Virginia, too often hospital networks are happy to use their branches in poor areas to get 340B drugs into the pipeline and then reroute these medicines throughout the hospital network to be sold at full price to patients of all income levels. As someone who voted for the original 340B law, I can assure you this was not congressional intent. Second quote is from the Reverend Al Sharpton. He said last year, "That's right, hospitals buy drugs for pennies on the dollar, then get to charge for the full price of that drug. This is a clear example of placing profits over people, not health care." He added that it bears repeating that most of the hospitals and clinics participating in this drug discount program were set up as tax-free entities for the express purpose of serving the communities around them, not well-heeled management. Yet growing the bottom line is exactly what many of these entities are doing. Finally, physician, former governor, and former DNC chair Howard Dean wrote, a 2021 review published in the New England Journal of Medicine found no evidence that profits gained by 340B hospitals resulted in expanded care or lower mortality rates for low-income patients. Another study concluded that 340B hospitals spent the same amount of time on uncompensated care for uninsured patients when compared to hospitals that didn't participate in the program. Even worse, a 2021 study by the Lown Institute found that the 10 hospitals nationwide offering the lowest levels of charity care all participated in the 340B program. So going to my last slide, our coalition's come up with 10 principles that we would like to see as part of an effort to reform the program. The program has been around for 31 years, yet there hasn't been any major efforts to reform the program. And you can understand why if you have this type of money at stake for one part of the covered entities under this program. We have a very diverse coalition of groups representing consumers, representing patients, representing providers, representing those who treat the underserved, including this group, that are members of our coalition and want to see real change. Now, fortunately, 6 U.S. senators have already issued a draft of a bill that represents comprehensive change to this program. And that's the first of its kind in many, many years. The comment period is open up until April the 1st. There are things we like about the draft. There are things we think need improvement. But this is an issue that should be on everybody's radar screen just because of the size and scope of what it represents and the fact that this program is designed to help the underserved.
Great.
Thank you very much.
Yeah, thank you very much. There's an old joke, or it's not a particularly funny joke in healthcare, that nonprofit hospitals are really non-taxed. They make plenty of profit. So thank you for that. Why don't we start on the end again with Wesley? And feel free, I said that you could start with your sharing stories and then policy, but if you'd like to combine, feel free. We're very flexible here.
Not a problem. Okay, so once again, I'm from Alabama. I've lived in D.C. and done work up here federally. But back at home, there's a lot of work to be done, especially on the healthcare side of things, where, man, it's it's a challenge. And I mean, listening to programs like the 340B program, although, you know, we always promote medicines and think that those are and pills pushing is the way to go a lot of the times. The overall wellness of our communities is not good, and that may be due to the economic struggles that a lot of us have down in those areas as well. But the access to just generalized health care is a pressing topic right now, because it's for instance, where I live, the nearest adequate healthcare facility that has, you know, things that'll cover most of the things that you need medically is over 40 to 50 miles away. So if I have an emergency and I'm already going to wait in line, usually about 3 to 4 to maybe 5 to 6 hours, you know, for just someone to just take me in, or a receptionist to take me, by that time you might be dead. And that's usually the case with a lot of the things that are going on in these counties, especially where I am. I'm on the west side of Alabama, so you heard of food deserts. I mean, it's pretty much a healthcare desert, kind of, if you so to speak. So UAB, they are wonderful with what they do. The University of Alabama, Birmingham, the hospital there is one of the top in the world, if not the top in the world. So what they have been doing, some programs that are now looking more towards extending their arm to the rural areas. What they have been doing is establishing their arm by buying out the established rural hospitals. So that sometimes they'll buy it out, and sometimes they'll figure, like, to keep the politics out, they may just, you know, extend a branch arm there and help them with some things financially, or programs financially that we don't have. But in my own county, in Greene County, we have getting an X-ray machine, or or getting someone to be able to operate that X-ray machine. That's a challenge. So you have these areas where, and I'm not shooting any of the DMV, the things that the DMV have going on are wonderful, and there are also some sides of the DMV that also are dilapidated, that could be updated. But where we are down south, the dynamics are totally different than up in the northern areas. Like, we are in the southeast, and if you've ever been to the southeast, and especially the rural southeast, you know as well as I do that there are things that you are in awe of, because it's the lack of resources, and the lack of networks, and the lack of information, the lack of knowledge, the lack of just knowing that these type of programs are available. That is the main thing that is killing our communities. Like, my community is almost extinct, so to speak, because of the fact that we don't have access, or we don't have an infrastructure that has these amenities. So people it takes flight. You know what I'm saying? Despite that, now there's a little bit more of an effort for those who have been out and seen more of the world to come back now and have an interest. But our lack of resources and amenities have caused us to be an almost extinct people on my side of the state. But at the same time, thanks to programs like Hope Credit Union, they work diligently in the community and try to find out what can they support financially, or they even have tools for the communities and resources to figure out what can they do financially to help these types of situations. The foundation, the Hodges Foundation, our Health and Human Services Department has also developed, as I said in the beginning, a rural health initiative. And this rural health initiative goes as far as down to the wire of training students, having training courses for college students and high school students to be able to transfer into those communities and be that go-in-between between the hospital and them and the hospital, between a community access resource and the hospitals. Because sometimes you need immediate attention, and sometimes you your attention is not as immediate as others, but you still need to see a healthcare professional or a healthcare provider. You know, so we want to have that rural health initiative program to be there and to service as much as we can, to be like the nucleus for a web, so to speak, of the counties that surrounding that. So you have a centralized location, and this is a model that we've developed, by the way. And if you, after this summit, if you guys want to get more information on that model, I'll be glad to give you that. But it was developed by our co-chairs of the Health and Human Services Department. They are in the mental health field, and they've been on the assisted living care and living care facilities as well. So they have witnessed the difficulties that have been taking place in trying to get adequate health care to these people in these rural areas. And now it's even more personal for me because my mother, and most people in her age demographic, the baby boomers, we know, have been experiencing high levels of dementia lately. So these baby boomers that are in the dementia stages, once they get into this assisted living care, or, you know, they send out occupational therapists, they send out physical therapists and whatnot, but the services are so low, it really takes away from even having them there, because if they're not able to get the financial resources or access to the resources to have them out there on a consistent basis treating these people, it's basically for naught, because once you start something, you already know how it is with a person with dementia or any mental health issue. Once you start it, you need to continue it at a consistent basis. But if it's a lack of consistency there, then it's almost like it's been diminished as soon as they leave out the door. You see? But it's more so of just a continued fight in trying to figure out ways of partnering, networking, establishing coalitions, however you all want to justify it here, and then moving in a plan of action, finding someone who can actually come visit these areas, or finding someone who knows people to put there in those areas to come back and get those resources for these communities. That way, we can promote centers for wellness and rural health initiatives all throughout these dilapidated counties and deserts. That way, we won't have that issue coexisting in the future, if you know what I'm saying.
Yeah, thank you for that. I mean, it brings in so many other issues like broadband access to rural areas so that you can do things like televisits, and, you know, I'm sure Tamika knows about all of that, and the STEM education development of the workforce. Oh, is that better? Hello. But I actually think I'm going to skip, and because Endura's work is very related to what Wesley was talking about when it gets personal, it's your family member. If you wouldn't mind going next and sharing your story.
Hi again, Endura Govan. So for 34 years, I had a wonderful business that I loved, teaching children, kindergarten through 12th grade, how to start their own business. Thought I would be doing that to the day I died or something else. My oldest brother, who had been diabetic for a long time, was an end-stage renal failure. He had just started dialysis. Didn't hear from him, went to his house, he was passed out. One more day, I think I would have walked into a corpse, a dead person. So as a good little sister, I told him I would give him 30 days of his 90 days proposed rehab. Well, 6 years later, he transitioned. And in those 6 years, I was able to have a front row seat to what it's like to work with somebody that the National Disability Institute called Black and Brown, Sick and Poor, Living Under the Bottom Rung. So their take is that you're not even on the ladder of life. He lived in Ward 8, D.C., so just being in a zip code that's overlooked, having multiple diseases. So I had to manage 8 chronic illnesses. But thankfully, as an entrepreneur that so many of us are in this room, we go through life using those same principles that we use to thrive in business to even govern our own lives. So these entrepreneurial eyeballs had to take my brother from being underserved to overserved, and it was not easy. It was dealing with several doctors who didn't know each other or talk to each other. So how can you get a holistic program going for someone's life when there's no connectivity to any agency, any set of doctors? Thankfully, though, I'm very persistent. I was able to get his A1C down from 11.5, which is really walking deaf, to about an 8. And that was without his help. So that was with me being what I call a sneaky chef. I'm just going to put it in your food. You're going to eat better because I now have the authority to fix your meals, to take you out for exercise, to help with your mental health. You had mentioned the growing cases of dementia. And as many of you in the health field know, dementia, they're using the term diabetes type 3. So my brother had early onset dementia due to diabetes. So when your glucose levels fluctuate, it's high one day, low one day, that takes a toll on your brain. So that's why we're seeing so many younger cases of dementia. I felt like, and I mean, I'm saying this jokingly, but I'm very serious. I felt like I was stuck in the episode of Good Times. It was just so stressful every single day that I now understand why caregivers often go out before the person that they are caring for. So if I didn't know how to use my network, which was calling the mayor, calling the deputy mayor of health, talking strong to healthcare people who wanted to over-medicate my brother on 12 medications, and I had to say, tell me what each one does. I mean, the normal person, we don't know that super long name and what it means. So I found out he was on 3 high blood pressure medications. That was unacceptable. And when I asked why, we want to get, this will get it down 1/4 of a point. Well, I can do that through diet. So in this world of healthcare, we, of course, have to put our own oxygen mask on and take care of ourselves as we fight for all of what we're doing in the community for advocacy. It's very expensive to be sick. My wallet was being drained, and I constantly asked, are there any funds for me as a caregiver? No, there's no money for you. Well, a year later, I found out that the District of Columbia is a direct care state, and if there's anyone in here that is a caregiver or deals with caregiving, find out if you are in a direct care state. There was $100,000 a year for me to take care of my brother. So when I asked the agencies, was there money, and they said, there's no money for you, I guess that's a true lie. There was money for them, but not money for me. And so what I found that was best in helping people, healthcare, I call it, it's more Del Frisco's, it is Nat Ruby Tuesdays. So don't look at it as my main course and 2 sides for $29.99, because that's not how you're treated. Every single doctor got paid for doing something that the other doctor didn't do. So as you look for resources, don't allow agencies or even doctors to bundle up what you're looking for. Find out what's available for diabetes, for those in end-stage renal care, whatever the issues are in your personal life. So there are monies for every single chronic illness. My background is financial literacy. So the first thing I did was I got his life in order, and I saved him about $200 a month on unnecessary spending. Well, when it was time to recertify my brother for his food stamps, they reduced them to $31 and said he can't have all that extra money walking around. And so then that forced me, because a diabetic cannot eat off of $1 a day and remain healthy. So then that forced me to find supplemental food programs that he qualified for. One is the farmers market vouchers, and it's seasonal, but it's $80 to $100 a month that he could use at farmers market vouchers. And I'm just giving examples of how, as we advocate for families in the communities, these are programs and services people don't know about. So every day we have senior citizens signing over the deed to their house to go into a nursing home because they don't know there's money available for their friends and families to take care of them. And when that person dies, it's not like they turn the house back over to the family. So we're losing assets, we're losing income, we're losing the quality of life of our elders who need to be in the community sharing their knowledge and their wisdom with the younger generation, because that's how many of us learned. It was from the seniors in the neighborhood who supported us, who bought our candies and said things like, I can't eat it, but I want you to win. And so as we advocate to keep our communities healthy with everything that we are forced to deal with people coming at us with guns blazing. I think I said on Monday, the new case of diabetes is a 10-year-old brown or black male. That is unacceptable. So when you look at policy changes, there has to be education. How do you teach a 10-year-old to eat healthy for his kidneys when, I mean, they want ice cream. They want to participate with their friends and not be excluded. So as an entrepreneur, that's how my 2 companies came to be, Color of Health, and I've always run nonprofits. So Color of Health Care is the nonprofit where I can share my knowledge, and that always have to be on the money clock, where I can get monies that are out here from health equity funds and give back to my personal community.
Thank you so much, and thank you for sharing your personal story. That's always appreciated and so impactful. Tamiko, do you mind if we go back to you now?
Sure. Just listening to everyone on the panel, I think we're constantly reminded of all the opportunities that exist for improvement in healthcare. And healthcare is not just my business, it's not just what I do. It's also my passion for so many of the points made here today. You know, being the older sister of a younger sister who has sickle cell, and watching the way that she is treated, watching her be reduced to a drug addict and treated in that manner, having an uncle with 5 mental health diseases that I care for, and having a mother pass away at 53 years old because they missed that she had pancreatic cancer and diagnosed her with acid reflux disease. And so it's more than just my work. I am very much motivated and activated towards health equity. And it's personal for me because, you know, just because I'm an African American woman, I am 3 times more likely not to survive childbirth. And for me, health equity needs to be at the top of our agenda because these disparities are unacceptable. For me to be more likely to not survive childbirth simply because of how I present, and for us not to be outraged and for that to be identified as the standard for our society is ridiculous, right? And that transcends, you know, people like to make excuses for health disparities, but that transcends socioeconomic class. Beyonce and Serena Williams almost died giving birth. And it was for one reason only.
They're on the financial razor's edge, those two.
Right. They were African American females. And that is rooted in a lot of things that we are afraid to speak out loud because it feels uncomfortable. It's rooted in bias. And it's rooted in the way that our society operates to really put a lesser value on Black and brown people. And we don't want to talk about it because it's something that we all have. We all have bias. It may be different, but we all have bias. It's a part of the human experience. But the irresponsible part about bias is to not know what it is and to not do the work to mitigate the negative impacts that could exist from it, that can happen from it. And because we're uncomfortable, because we want to pretend like we don't see color or we don't see race, we don't see race, we don't see nationality, and we don't want to have that discussion, we continue to operate within our own bias as we navigate the world. And what that does is it creates health disparities and it creates a loss of life, and it creates a loss of life for people who look like me. And that's a problem. And so what I really work towards in my health equity work, among tons of other things, but number one, first and foremost, let's make understanding, knowing, recognizing, and mitigating bias part of legislation. If you're going to be in healthcare, you need to take an implicit association test. You need to identify what your unconscious biases are. You need to be able to do the work. You need to be required to do the work in order to maintain your license so that you are not killing people, quite frankly. And then I think that we all need to be held to that same standard. As an individual navigating the world, we need to know what our own biases are, and we need to understand the tools and techniques to mitigate the negative impact. We also need to make sure that we are providing examples for young people so that I'm very much a supporter of Black men in white coats, which is really showing young people early on that they can have a career in medicine, that you could be a doctor, and really showing our young Black and brown little girls and boys that that is a great career, and it's a career that we can help them obtain so that it's not something that looks so far out of reach. And so we need to make sure that we are having diverse teams within healthcare and that we're empowering those diverse voices so that we can have a perspective that includes saving the lives of people who look like us, right, who look like me. I think the reason why we tap dance around that is because we don't really acknowledge the fact that we have to be intentional around diversity, equity, and inclusion. If you look at me and don't see an African American woman, that's not a flex. That's a problem. Because you have to see who I am and how my needs, my issues, and my circumstances are unique. And I have, you know, people say you can't expect it to be customized. It has to be customized.
Right.
You have to treat me for what I need. And you can't have a blanketed approach, because that's how we get into the space that we're in, which is sitting in these health disparities that are riddled throughout our society. And what's troubling about that also is that when we talk about bias, we think that there are some people who are immune to it. You know, when I was working in major healthcare systems, the most I would issue the IAT, I always required an implicit association test, and I worked with physicians, and there's a lot of African American physicians that would call me and say, this thing is broke. I'm not against black people. It's saying, this thing is telling me that I place less value on black people and I'm black. Your thing is broke. You need to fix it. But no, it's not broken. It's an unconscious bias, and the reason why that exists is because of our society. There is everything that we're doing every single day, imagery, conversations we hear, conversations we're a part of, things we see, what's on TV, ads, images, information, interactions that we may have been a part of. All of that is an unconscious download that's happening to place certain value on individuals that look a certain way. And it's not like we can control it because it is unconscious, but we can be more aware of it. And if we're more aware of it, we can actually do the work to make sure that it's not having a negative impact in healthcare. And so that's one of my big focuses, because our words aren't heard. They're not taken with the same sincerity or the same level of interest as our non-diverse counterparts, and that is due to bias. And the more we talk about it, the more we hold people accountable, the more we commit ourselves to do the work and acknowledge it, the more we encourage each other to do the work and acknowledge it, then we can actually have a society where black and brown people are not dying from any, name it. You can name the condition. We can throw it out kind of like pick a card, and we are still impacted at a disparate rate. Mm-hmm. And so we have to be honest. We have to talk about the things that make you feel like you want to cringe, and we have to be uncomfortable, because until we do that, we are just going to continue protecting the status quo and being the definition of insanity. And so I very much am into health equity. In the health equity space, I work very diligently to identify the root cause of health disparities, and I want us to get to a space where we are legislating requirements for individuals, organizations, and institutions in healthcare to be able or to have to do the same.
Thank you so much. We have about 15 minutes left on the panel, and I'd like Dr. Muhammad to go next, please. And do you want to start with your video or end with it, or middle?
Brady, were you able to find the video? No? It's okay.
Okay, never mind.
I'm going to post it on my LinkedIn. It's all right. I won't be long, but I promise to be strong, okay? So I want you to picture this. Imagine spending time going to medical school, graduating, becoming a surgeon, doing your fellowship, doing your residency, and then spending 15 years of your own time, your own money, dedicating into building an institution, only to have to fight against the structures that don't want you to care for your own people. And I have my business partner, Dr. Jeffrey Dormo, in the audience today, and that is his story. Together, we built a $20 million facility right here in Laurel, Maryland. And we talk about healthcare disparity and the discrimination against patients, but I'm talking about against doctors. I think Dr. McGuckin is here somewhere, and Dr. McGuckin is white, but he treats primarily black patients, and he's experiencing the same level of hate. What kind of hate am I talking about? I'm talking about death threats. I'm talking about sabotage, from refusing to accept your patients if you need to refer them somewhere. I'm talking about shadow patients who come in or shadow employees that come and steal your trade secrets and take them somewhere else. We literally were at having so many threats that Prince George's County Police say, y'all should just go and get firearms. This is what we faced in building an independent Black institution. And that's why I'm here today, because Black institutions are needed. I'm listening to your case about your brother and him being on multiple blood pressure medications. We catch that kind of thing all the time. Dr. Dormo's right there. We catch it and fix it all the time. We saved almost 40,000 lives and limbs here in the DMV. Dr. Dormo can give Dr. Dormo a hand for his work in the community. We have been working with independent physicians and surgeons around the country to help them come out of the big box system so they can offer some of that customized care that you talked about. Thank you to you, because when you guys were with Chartered Health, you supported us. As soon as you all went away, I'll say all hell broke loose. So I'm saying that to say that if we have less than 5% of African Americans that are even physicians, how many even own their own independent facilities? And this is where our support needs to be. We've looked into going into Alabama and looking to develop an independent system. We've seen abandoned hospitals that we saw that we could get for as little as $1 million. But we've spent all of our money fighting frivolous lawsuits and against frivolous cases. This is a huge antitrust case. We even had situations where the hospital should sign off on a basic patient transfer agreement. They held that up for 1 year, and we had a brand new $20 million facility that we could not use because the state of Maryland could not even give us a license because the University of Maryland refused to sign off on the patient transfer agreement. We finally got the patient transfer agreement, and guess what they started doing? Sending their patients over to us. So I'm saying that there's a case to be made against us supporting independent institutions. Yes, Black primary care physicians and their independent offices are important, but Dr. Dormo is a triple board certified, fellowship trained vascular surgeon. So we need surgeons and interventionalists, people who can do something if you're sick and not just write you prescriptions and put you on 4 to 5 blood pressure medications. So this is why I'm here today. This is why I'm grateful to be working with Kevin and his team and his staff, because this is where the money is. This is where and this is happening, this is an epidemic. This is happening all around the country. In Ohio, we know doctors in Ohio this is happening to. It's happening in Chicago. It's happening in Alabama. It's happening in Louisiana, where our independent Black facilities or independent facilities that are serving our underserved communities are under attack. And they can barely afford to stay open because they're so busy allocating resources against those attacks. So what do we want? We want an antitrust case. We want to put some data around it so that maybe some of this 340B money can be allocated to independent facilities to help subsidize. I have so many surgeons and doctors who are saying, I'm so tired of this system. I can't practice real medicine. I can't be a real clinician because there are certain parameters that tell me that I have to do certain things, and my job and how I'm doing on my job and how I'm evaluated as an employee is not based on how well I treat you or how well I treat your brother, but how well I implement the rules that are in place that are not so much in the best interest of the patients. So when you see an independent Black facility, if there's anything you can assist us in doing to help subsidize those facilities, to help build more facilities, let's get more Black doctors together so we can form groups. They can support and support independent physicians like Dr. Dormo, like Dr. McGuckin, who's here, who are here to serve you and will serve you above and beyond what the insurance company tells you or tells them that they should do. Thank you.
That was very strong. Thank you. And last but certainly not least, Dr. Leith, if you could share your perspectives, and then we'll sort of recap the session and open for Q&A. Yes, ma'am.
Thank you. And, you know, as I said when I opened, that I wanted to circle back to everybody on the panel, because I do want you all to keep Alabama in your mind, because my focus with working with the Tuskegee-Macon County Community Foundation is focused on maternity care. There are lots of maternal care deserts in Alabama, and the foundation currently focuses on 12 of the 18 counties that you mentioned, Wesley, and you know, most of them are on the Midwestern side of the state. There are a couple that are on the eastern side. Macon County, of course, is central, and it's the 11 other counties that they work with. So Alabama is deemed the worst state in terms of maternal deaths. And, you know, when the president and CEO of the foundation talked to me about some of the stats, you know, some of the policies, she shared with me that it was just in recent years that the ban on midwives was lifted. That was a 40-year ban. 40 years. Why does it take that long? Then the syphilis experiment. I have heard so many people say how tired they are of hearing about it, and that people need to get over that. Who's going to get over that? You know, there are family members who are still reeling from that and who are still impacted by it. The whole thing with the maternal death rates, I mean, looking at that, you know, it's not just that the woman died at that point and everything is over. That has implications for intergenerations. And so we can't just walk away, close our eyes, and think it's going to go away, because racism is still alive. I mean, the Black Belt counties have a legacy, and that legacy is perpetuated today with the differential power. And we have to take that into consideration, but we have to be very proactive. There aren't any hospitals in the areas that are most immediately being addressed. So we can't look at community benefit and how you would redistribute savings from a nonprofit hospital who's obligated to do that. There is no hospital. So a person who is pregnant that has to travel 30 minutes or more to get to a hospital, if they're having complications, their risks already are zooming up. And when you look at the overall maternal mortality rate for the state, it's like 64.63 per 100,000 live births. For Black women, it's 100.07, I believe, per 100,000 live births. Again, those numbers are huge, and you can't just put your head in the sand. So what we're looking to do is to build an ecosystem. And we have had an article published about it a few years ago, actually. And we are ramping up our activities now because we need to have it a little bit more diverse than maybe what we were trying to achieve. It needs to be larger because there's so much need in the state that there's not one single entity that can actually address everything. It's going to take a lot of brain power to be creative and innovative so that you can replicate certain types of models. And there needs to be policy analyses that looks at it from a lens of ethics. There needs to be, just a whole comprehensive way of doing things and planning and implementing new strategies. So, we're looking at workforce development. We're looking at interprofessional teams. We're looking at how you can engage community health workers. We're looking at that, but here's the thing. They are trusted sources in a lot of communities, but their reimbursement for their services is questionable, and so you can't really sustain them. But they are a good resource. So that is something that we would like to see changed. That, that's a national problem. It's not just an Alabama problem, but that is something that is high on our radar. We want to also see that there's support for midwives beyond just raising the band. We also want to see doulas be used. And all of that, I know, is probably something that's going to take some time, but we don't really have a lot of time, because if things keep going down the road with the trajectory that it is, where will we be as a Black people? And that's all.
That's right. Thank you so much. Thank you so much. So we have a few minutes for Q&A, so if you want to raise your hand while I'm just sort of recapping what I think I heard today, we'll bring a microphone to you. Is that right? What do we have, about 10 minutes? Brady, is that right? Great. So I can do a short 10 minutes. Yeah. No, we'll wrap it up. So, we've heard about the complexity and all the interrelatedness of a lot of different issues, so I just want to sort of recap what I heard back. We know rural health is a big issue, and we talked about how there's staffing shortages that are exacerbating the problem. Obviously, there's funding problems. Even things like broadband might be a new technology that could be brought in to remedy some of that. We heard about the education pipeline, right? Getting more diverse providers, and that has to start with encouraging young Black and brown kids to go into STEM topics, curricula, right? And then we have to revise our medical education, because that bias, to your point, the Black doctor probably has bias because the medical education they received is biased, right? There's also issues between state and federal, right? The feds manage a lot of the money, but the states often set the rules. So all to say, this is incredibly complicated. Midwives licensing is done at the state level, not the federal level. We talked about diversity in terms of access to emerging technologies and research, right? So encouraging that participation in your communities to make sure that people are signing up for clinical trials, to make sure that when medical education is delivered, it's based on evidence, and that evidence is based on research. We talked about transparency, especially with the 340B program. Where is that money going, right? And so as taxpayers, we can all advocate for better transparency to say, where are these funds going and how are they being allocated? In the 340B program, when you read all the big, like the Commonwealth Fund wrote a piece about it, they're not worried about the patients. They're talking about why the pharma companies don't like the 40B program and the hospitals. So again, we should be advocating as individuals and as patients for better administration of these programs for patients. And then last but not least, the financial incentives. We don't have a lot of Black-owned venture capitalists. We don't have a lot of Black-owned PE firms, private equity firms. And those are the organizations, in addition to all the nonprofits, that we would want making investments in clinics like yours or clinics around the country. And so all to say, healthcare inequities is incredibly interrelated, but if you're focused on something, don't boil the ocean. Pick something you're passionate about. Sign up for the newsletters of an association that's already working on it, and sign your name to every grassroots letter out there. That's the most leveraged way an individual, and obviously continue to support people like Kevin and Brady who are doing this good work. Thank you for hosting this event. Question?
the 6 senators released the draft to try and get more input from the public, including stakeholders. And that draft was a result of an initial outreach by those 6 same senators. There are 3 Republicans and 3 Democrats. They're led by John Thune, Debbie Stabenow, Ben Cardin. I'm drawing a blank here. Hattie Murray, I think, is one of them. And there are two others on the Republican side that I can get to. If you go to our website at ASAP 340B, you'll be able to see it. I think it's good that there is at least an effort to try and find a bipartisan solution on this. I know in this town it's hard to do these days. But I think that that's good because, you know, I don't think you can approach this as a one side versus the other. There are many large entities that are part of this program. PBMs are part of this program. Pharmacies are part of this program. Obviously, clinics are part of this program. Obviously, farmers providing the drugs for the program. And you have a lot of entities that, you know, receive those benefits. But, you know, I think the concern that the coalition has, and we're open to talking to hospitals, the concern is that when you have hospitals only essentially getting 87% of the dollars in the program, you heard about some of the practices that she talked about. This falls in line with a lot of other practices that, you know, I would say a lot of hospitals are engaged in right now, unfortunately, which do not benefit the patient, which do not benefit expansion as to how many different types of entities you do business with. They end up looking like they're anti-competitive. You know, and look, I used to represent the hospital community, okay? So when you talk about CON and trying to limit, you know, the types of entities that can provide service in a community, or you talk about, you know, buying all of these practices in minority communities to help further, you know, consolidation, integration. A lot of these things are related. Okay, and you know, the question is just whether or not, you know, what's in the best interest of the patient and what's in the best interest of serving the underserved. That's what I would say.
Any other questions? Yes, sir. Oh, yeah, here, I have one. Try not to drop it. Get it?
Good afternoon. It's quite interesting to listen to this panel. I was actually invited by some staffers on the Hill and say, hey, Alex, you got to go check this out. And the reason why is you just mentioned there are a few African-American controlled firms
The venture capital
in
and
the
private
PE
equity.
space, and we are one.
Yay.
And so it's, when you listen to all of you, the biggest problem we have is, as the brother said, is the knowledge, the access, and the connecting those pieces together. Because I'm in charge of quite a bit, and we literally can find recipients. That's a disconnect.
For your money?
For capital.
Okay,
They've
so
got-
what's your name?
5 people right
What's
here
the
that
name
would
of your
like,
company?
yeah.
So that's something that goes back to policy. It's always policy. But how do you get PE guys
Yeah.
to appreciate your story
Yeah.
when they don't look like you? But they trust me, but I don't have access to you. You see the catch-22?
Allow me to introduce you to 5 people that would like your money.
Yeah, so
6.
we would like to help and work with you and
Wonderful.
get your particulars. I'm very disturbed to hear about what happened. You're in my neck of the woods. I'm in D.C., so you live in Ward 9.
Can you tell us your company name and your
Yes,
name
our
again?
fund is called Best Trust Fund.
Best Trust
Fund.
Okay.
And it stands for Blacks Economic Security Today Trust Fund.
Great.
It's exclusively for blacks. So how I got here, I think, is providential. We as black people always believe in the Lord hooks you up and makes things happen. So this is not a difficult issue to fix, and we do have friends on the Hill that we can be much more we can twist some arms. How about that? Okay?
I think that nicely wraps this session up with a bow. I would say that that is the best way to wrap up this session. Thank you all panelists. It was a very large panel, and I'm sorry if all of you didn't get as much time as you'd hoped, but please reach out to them. And, they're obviously all on LinkedIn, but obviously Kevin and Brady also have their contact information. And the last thing I would say is that if your company does matching contributions, please consider giving Kevin and Brady's organization some of your donations. They're wonderful and working really hard on important issues. So thank you very much, and thanks for inviting Diversity Works, Kevin.